Hello and good day. So today we're going to continue our discussion on your critical care nursing, and this time we'll be talking about your cardiomyopathy. Okay, so in terms of your cardiomyopathy, has something to do with the heart muscle disease associated with your cardiac dysfunction. Okay, if you're going to dissect the word cardiomyopathy, the cardio means your heart, and then your my is your muscle. Okay, and as you can see here on this illustration, there are like three types of your cardiomyopathy, and by definite by name alone you already know, and you will already have an idea of what kind of myopathy it is. Okay, now it is classified according to the structural and functional abnormalities of the heart. So as you can see here on the first illustration, this is the normal heart. Okay, now this one, the first one here, this is what we term as your DCM, or your dilated cardiomyopathy. As you can see here, the muscle part here is dilated. Okay, and on the other side, this one, this is what we term as your HCM, or your hypertrophic cardiomyopathy. Now, if we say hyper, it means like it became bigger, and tropic is something to do with the muscles. As you can see here, it's a bit enlarged in terms of the cardiac muscle. And we all know that if there's an enlargement of this one, constriction will actually follows. And this type here, this is what we call as your restrictive or constrictive cardiomyopathy. Okay, and we have the other one, which is your arrhythmogenic right ventricular cardiomyopathy. Okay, now let's move on here. How about its pathophysiology? So a while ago, we've talked about the different types of your cardiomyopathy, and then the baseline to that, of course, is your etiologic factor. What triggers your cardiomyopathy? It can be familial, it can be developed, or a disease process. You acquired this one through stagnation, or by you know overuse of some substances, or you know smoking, something like that. So those are your etiologic factors. Here comes now your type of cardiomyopathy. So of course you will be diagnosed, or you will be undergoing a diagnostic laboratories tests and other some sort of testing. With that, it will be labeled as if it is dilated, hypertrophic, or restrictive. And what is happening here is the blood flow becomes stagnant, okay, or there's a slow movement in terms of the blood flow, okay, and this is quite evident on the chambers of the heart. Okay, it's because the heart is dilated, it is hypertrophic or restrictive. And what is happening is the ventricle's ability to pump blood actually reduces significantly. Okay, and with that, it means that there's going to be a decrease in your cardiac output. And of course, if it's left untreated or left undiagnosed and it progresses, it can actually lead to your heart failure. So that's the simple pathophysiology of your cardiomyopathy. Now, how about assessment and diagnostic findings? Chest x-rays reveal heart enlargement and possibly pulmonary congestion. So the simple, CXR that you will be undergoing the radiologic department, it can be seen, or it can be concluded if you have heart enlargement. Now, the cardiac catheterization is sometimes used to rule out coronary artery disease as your causative factor. And your endomyocardial biopsy, you already know what's the meaning of biopsy, right? That they're going to, to get a sample, and then it will be sent to the laboratory for analyzation. Okay, that is your endocardial biopsy. How about the management of the cardiomyopathy? Now, the medical management is directed towards identifying and managing possible underlying or precipitating causes. And the first one is correcting the heart failure with medication, a low sodium diet, and an an exercise or rest regimen. With this one, it can actually alleviate what you're feeling, or it can actually stop or cease the process of becoming chronic cardiomyopathy by identifying already or by undergoing medical treatment, and of course a low sodium diet. Now, controlling your dysrhythmias with your antiarrhythmic medications, and possibly with an implanted electronic device such as an implantable cardioverter defibrillator. Systemic anticoagulant to prevent thromboembolic events is usually recommended. As we all know, that the cardiac muscle has been altered, and the flow of the blood is also um, sometimes impossible to penetrate, or the movement is very slow. And of course, if your diet is high in cholesterol, or you are a bit heavy, you are a bit overweight, of course thrombosis is actually very very evident, or it's should I say, it is possible. That is why systemic anticoagulant is being recommended. Now, if the patient has signs and symptoms of congestion, fluid intake may be limited to 2 liters each day. Of course, if you have congestion, it can actually also alter your breathing pattern, especially if it's your pulmonary congestion. Now, let's go here. Patients with HCM, or your hypertrophic, is it hypertrophic? It is your, hypertrophic cardiomyopathy should avoid dehydration and may need some beta blockers. Now, this is to maintain cardiac output and minimize the risk of having left ventricular outflow tract obstruction during your systole. Now, your patients with hypertrophic or your restrictive cardiomyopathy may need to limit physical activity to avoid the life-threatening dysrhythmias. So, more or less, they are on the rest state so that arrhythmias will not be triggered. A pacemaker may be implanted to alter the electrical stimulation of the muscle and prevent the forceful hyperdynamic contraction that occur in your hypertrophic cardiomyopathy. How about your medical management? In terms of medical management, we have what we call your non-surgical septal reduction therapy, also called as alcohol septal ablation, has been used to treat obstructive hypertrophic cardiomyopathy. In the cardiac catheterization laboratory, a percutaneous catheter is positioned in one or more of the septal of your coronary arteries. In terms of your surgical management, heart transplantation is viable, and in some cases, a left ventricular assist device is implanted to support the failing heart until a suitable donor heart becomes available. So that's actually already being done overseas, but I'm not really quite sure if this one is already been performed here in the Philippines or in any other nearby countries. Now, here in terms of your heart transplantation, this is what is happening. This is what we term as your orthotopic transplantation. Is the most common surgical procedure for cardiac transplantation. And if you're going to see the illustration and how it was actually done, now this one is the recipient's heart is actually being removed. Of course, it's because it will be replaced, and the donor heart is implanted in your vena cava as well as in your pulmonary veins. Now, some surgeons prefer to remove the recipient's heart and then leaving a portion of the recipient's atria with the vena cava and the pulmonary vein in place. The donor heart, which usually has been preserved in ice, if you've watched some of the episodes in The Good Doctor, they have an ice box for vital organs that is actually for the transplants. Okay. Now, so it is actually being preserved in ice and prepared for the implant by cutting away a small section of the atria that corresponds with the sections of the recipient's heart that were left in place, as you can see here on our illustration. Now, the donor's heart is implanted by suturing, of course, the donor's atria to the residual atrial tissue to your recipient hearts, just like what is this one. Now, after the venous or atrial anastomosis, I know you're familiar with anastomosis. It's like combining two tissues or something are completed. Now, the recipient's pulmonary artery and aorta are sutured to those of the donor heart, and the patient who have had the heart transplants are constantly balancing the risk of rejection with the risk as well of your infection. Okay. Now, how about this one? The heart transplantation. What is happening here is most commonly a patient receive your tacrolimus or your cyclosporin, mycophenolate mofetil, or acitroprin, and corticosteroids to minimize the rejection of your heart transplantation. Now, the 1-year survival rate for patients with transplanted hearts is approximately 81% to 95%, and the 10-year survival rate is approximately 50 to 70%. Now, the pacemaker therapy, I know you're familiar with this one. I think you've seen this one. The pacemaker, of course, this is an electronic device that provides electrical stimuli to the heart. Okay, they also be used to control some tachydysrhythmias that do not correspond or respond to your medication. So we have biventricular pacing, also called as your resynchronization therapy, may be used to treat advanced heart failure that does not respond to medication. So you can see on this illustration. So this is your pulse maker. And then here we have the leads that is being connected to your right atrium and left ventricle. So with regards to this one, it can be a permanent or temporary. And the temporary pacemaker are used to support your patients until they improve or until they receive a permanent pacemaker. Okay, usually done during an open heart surgery. And temporary pacemaker are used only in hospital settings. Okay. Moving on here, your atherosclerosis. It is a Greek word for ather. It means gruel or paste, and sclerosis means hardness. And it begins when the inner protective layer of the artery, what we term as your endothelium, is being damaged. And we have 3 known causes of this one. We have first is your elevated cholesterol, triglycerides in the blood, hypertension, and of course is smoking, until some deposits or some of the plaques are being restored here in our inner layers of our arteries. Okay, so what is happening here? The deposition of the fatty substances, cholesterols. It can also be a cellular waste product, calcium, and what is happening here? There's a buildup of atheroma, or what we term as the lipid plaque, with the fibers covering, and blood flow in the artery becomes partially or completely blocked. And that's the time that the blood flow or the circulation of the heart is being impeded. Okay. And of course, the thrombosis can occur with this one, and the amount of blood through the artery is being reduced. Now, in terms of factors, we have your uncontrollable, of course, the age of 65 years and older, heredity and race, environmental and genetic tendencies, like most likely African Americans, Mexican Americans, and the things they are very prone to this one. Hypertension, which is more severe in African Americans than Caucasians, and high rates of obesity and diabetes, and Mexican Americans, American Indians, and Native Hawaiians. As you can see here as well, the atherosclerosis is more evident or has a greater factor to men compared to women. And men have MIs at a younger age, and after menopause for women, the death rate from coronary disease rises, but it never reaches the risk factor to men. And of course, for those who are tobacco lovers here in this class, it is actually a major risk factors as well. The smoker's risk for an MI is 2 to 4 times than, of course, of the non-smokers. And smoking is the biggest risk factor for sudden cardiac death. And it also acts as other risk factor to increase greatly your coronary heart diseases. And of course, exposure to environmental smoke also increases the risk of heart disease to non-smokers. Okay, and how about this one? The high blood cholesterol. The level below 200 milligrams per deciliter have relatively low risk of your CAD. 200 to 239 represents a moderate but increasing risk, and 240 and higher, the risk for your CAD is about double. You also have your low density lipoprotein, which is the bad cholesterol in our body. Your LDL, this is deposited in the artery walls and increase the risk of coronary heart disease. Your LDL level of less than 100 milligram per deciliter is optimal, and a therapy goal of less than 70 or higher is at risk for MI. And as you can see here, of course, this is the good cholesterol and this is the bad one. So the deposits of fats in this kind of disease for these people is very high, and of course the normal bad blood flow is being narrowed down. Your high blood cholesterol, we have your HDL, removes cholesterol from tissues and transport the excess cholesterol back to the liver to be metabolized. And triglycerides is the most common type of fat in the body that the rate of atherosclerotic development seems to be accelerated by the combination of high triglycerides with either high amounts of LDL or low amounts of your HDL. Hypertension, of course, it is a major risk factor in terms that is termed as the silent killer because it has no specific symptoms and early warning signs. Many people actually have high blood pressure, but they don't know it unless their blood pressure is being taken. It's because they cannot feel, or it is asymptomatic, if they are being dizzy, or they have headache, or any other some sort of high blood pressure. Okay. How about in terms of physical inactivity? People who are stagnant, people who are not moving, people who are actually physically challenged or under the state of coma, they have the tendency to actually have your atherosclerosis as well. Now, regular, moderate to vigorous physical activity helps prevent your cardiovascular disease. That is why it is always recommended for you guys to, or for all of us, to have at least 30 minutes of exercise per day, whether you can just do walking, brisking, jogging, yoga, or playing your favorite sport. 30 minutes is already um, a great number of time for you to prevent having atherosclerosis. Okay. The next one is the weight. It has something to do also with being obese or being overweight. Of course, the fat deposit is very high and very evident. That is why we really need to be doing some exercises. Now, how about your diabetes mellitus or DM type 2? What is happening here is that the insulin here, and then the glucose, the insulin receptor, actually the cells fail to respond to insulin properly. And of course, it is also associated with stress. Yeah, atherosclerosis, excessive alcohol intake as well. The risk for the heart disease is moderate drinkers is low. In moderate drinkers is lower than in non-drinkers. So maybe from time to time, it's okay to drink red wine, but not too much. Okay. So this is the third part of your critical nursing care towards your cardiovascular system. So a while ago, we've talked about your cardiac myopathy and your atherosclerosis. So we're going to have to discuss one more video recorded lecture, and I'll see you again next time. Thank you, everyone.